not talking about them, but looking at the joints that held this together. And now we want to name all these ligaments. So the anterior longitudinal ligament is what we talked about when we looked at things like whiplash, and you asked the question about tearing, breaking off a piece of it, avulsion. And so the anterior longitudinal ligament is running up the front of the vertebral bodies here. Okay? So it goes all the way down. If you look at the slide stuff, it'll say it extends from the atlas to the sacrum. So it's covering the anterior side of those vertebral bodies all the way down, except the coccyx, which is very small. And so that's going to help prevent you from doing hyperextension. We look at it often in just the cervical area because that's where we see whiplash, but it keeps you from extending your spine back too much. And on the opposite side of the vertebral bodies, we have the posterior longitudinal ligament. And it's a little narrower, but it still helps in a lot of ways. It's a little bit weaker, and you won't be able to see it. I can't really point it out looking at a skeleton. Because if you start to classify, when you think about these ligaments, think of, well, there's the anterior longitudinal ligament. We're going anterior to posterior. And so the anterior longitudinal ligament is just in front of the vertebral bodies. The posterior longitudinal ligament is just behind the vertebral body. But what's actually, there's a canal behind the vertebral body, right? That's the intervertebral foramen. Took these out here so nobody could mess with it. So I guess that's a better way to. Your anterior longitudinal ligament's out here, right? This is spinous process. Here's the body. And your posterior longitudinal ligament is here behind the body. So then what would be right behind that? Yeah, the spinal cord. And I'm going to show you why I was making that a key. Because this is a little narrower and weaker than the anterior, but its job is to prevent hyperflexion of the spine. Now before we get there, and it's shown here, I know I orientated this picture before for you, it's just not as clear. There's the anterior longitudinal ligament, and this is the posterior. And so I can't draw it that way on here, but your spinal cord, of course, would be right behind that. The posterior longitudinal ligament, though, when it gets up higher, right, just before it's going to go through the occipital, or the occipital bone, the magnum foramen, excuse me, it becomes what's called the tectoral membrane. So when it crosses the axial joint, it's going to go into the actual magnum foramen here. So once it comes, you can't see it because it's inside, but once it expands up to this area, it's going to go, you got to picture this into the base of the skull, and it kind of expands right, inside of that magnum foramen. So it's going up towards that brainstem, and it's called the actual tectoral membrane. So another way to say that is you'd say, well, the most superior portion of the posterior longitudinal ligament becomes the tectoral membrane. And they're all kind of continuous, but that portion is called the tectoral membrane. And you're going to look at that. That's not just a random fact. When you look at things like herniations through this area of the brainstem, you're going to look at this tectoral membrane again. And the other one is my favorite rap star ligament flava. Flav. Y'all know who that is? Clock. No. He showed up at New Year's a couple of years ago, and I hadn't heard of him in 20 years, it seemed like. Still going. Anybody listen to him still? I don't. What? Yeah. I gotta use that next semester. There's some things I'll say that I steal and use for the next class. Gets rid of some of my older ones. That's pretty good though. Not the cloud. Yeah, TikTok. He should be big on TikTok. I get it. Yeah. All right, but the ligament flava holds the lamina together. You got to go back when you start studying this. When you're really saying, "Oh wow, it's time to focus on A&P I next weekend," you got to go back to that first picture. starting to understand where ligaments are and all these different things, all begins with that picture that had it color-coded. Remember that one? It showed you the different parts, and we had the pedicles, and here's our lamina that forms that vertebral arch. So as these stack together, the lamina are each connected by ligament flava at every level. And you can see those in this picture. It's just, when the first time you see it, it doesn't make a whole lot of sense. But since the pedicles is cut, here's the vertebral arch, and connecting them is these ligaments called ligament flava. Basically, along with other ligaments, just helping to keep those areas from separating. Now, we do not want our spine being that mobile. We should have a very delicate spinal cord in it. Back to this picture we saw once before is another ligament. I put it in purple, whatever color that is here. And from C7 to the sacrum, all of your spinous processes have a ligament that runs through there. So when you look at, say, supraspinous ligament, then you pick out C7, that larger spinous process, and you go all the way down to the sacrum. This ligament runs on the tips of the spinous processes and connects them all together, all the way up to C7. The spinous processes themselves have another ligament between them that we mentioned yesterday. So this is actually called the interspinous ligament. But there's a separate ligament that's running down these spinous processes, not just from one to the next, all the way connecting all of them, and that's called your supraspinous ligament. When it gets to C7, it does something similar to the posterior longitudinal ligament. It fans out and becomes ligament nuchae. Oh, the way I like to say it. So this ligament portion here. I mentioned this before when we talked about the drill sergeant's bump slide, and we said, well, you have an external occipital protuberance that's here, and when we bent our head down, it was on that slide, you can feel this ligament, because it's going from C7 to here. And so when you tilt your head down, that's going to get tight. Now this picture ties them all together. I know it's not a fancy graphic, it's nothing, not 3D, it's, when you first see it, it's not easy to read, but we're going to spend time orientating this, because this kind of shows you the location and place of all those different ligaments. So you have to first off go, well, here's anterior and posterior. So here's the vertebral body. Here's the spinous process. Right? So in this picture, you got to get it right. Now we're sitting like this. The body's out here, the spinous process is there, and we've taken a cross section, a sagittal section really, to where that's sitting that way. And then we cut it in half. Right? I want to help you orientate really good here. So the anterior longitudinal ligament is out here in front of the vertebral body, and then you have the posterior longitudinal ligament that is just behind it. Okay. You can see here, this is the pedicle. Is that black easy enough to see on there when I'm doing that? Not really. Well, still got it. Still got it. I mean, a weaker man would have just went down. Pedicles. Now there's your pedicles, and you can't really tell how the vertebral arch is here, but remember, you have lamina. Go out here, that's your pedicle, and then you have your lamina. I'm going to kind of draw it this way so it looks like a little more like what we picture. And then here's ligamentum flava that's connecting them, the lamina. So that means our spinal cord is going down through here, just behind the posterior longitudinal ligament. And then between each spinous process, we have the interspinal ligament. And then back here, we have the supraspinal or supraspinous ligament. This area here would be articular processes. So when we talked about how they stack on top of each other, when I was talking about the zygopopocyle joints, that's what we're seeing here, is there it shows the connective tissue capsule over it, but each one of these is those separate joints. So that's what we're seeing when I circled there. The only thing I didn't mention on here, I think, is the disc. The intervertebral disc would sit between the vertebral bodies. That's how it's all set up. We'll leave it at that for a second. Now if we go to, I'm going to switch back to black so I don't give importance to stuff that's not. Vasculature of the vertebral column is not a whole lot to look at. As other areas, it has an arterial supply, and I don't want to spend, definitely don't go and label this picture. The only point I want to make to you here is that the abdominal, sorry, let's not say abdominal, the aorta provides at every level a segmental artery. And that segmental artery is supplying the vertebrae and the supporting structures inside of the vertebral canal. That's it. As far as I want you to go with it. So at each level, you're going to have these little small branches that come off and supply the blood to the spinal column itself. That's called a segmental artery. The rest of that labeling is not important. On the venous side, it's kind of unique because it has anterior vertebral plexus, both internal and external. So this is the anterior. So this is anterior external plexus. This is the anterior posterior plexus. And then you're going to have a posterior vertebral plexus that's internal. Internal meaning inside of the spinal canal itself. And then external posterior vertebral plexus. Okay. So there's externals are on each side and internals are in the canal. The reason this is important, and I took it out of the slides so we didn't have to discuss it more, we will later, because this area is actually valveless, and it's an area when you start talking about cancers and metastases, generally when you see cancer, they can predict that it's going, if it's like breast cancer, where do we know the first place it's going to metastasize if you have breast cancer is to the first lymph nodes, right? So they're checking those, and then it goes on from there. Well, cancer travels in a predictable path, kind of like your circulation does. So how did cancer get to an area? You can work your way either forward or back to figure that out. But because this area is valveless back here, they've seen cancers that like get to the brain that came from other, you wouldn't expect it to be there. And it traveled through this valveless system here at your vertebrae. You don't remember any of that for now. That's related. I know. Why did I say it? Why did I say it then? I give you a little bit here and there. A little bit here and there, and then you get it later. I was just saying that at the end so you didn't write it down. Did you already write it down? Okay. All right, skeleton of the ribs. We're going back to bones. So the bony thorax, what we call our ribs most of the time, our thoracic cavity is actually called our bony thorax. And that includes 12 ribs along with our costal cartilages. These are costal cartilages out here. And then you have the sternum. So we're going to work our way all the way through this and keep using this picture. The purpose of the bony thorax is to protect things like your lungs, your heart, your liver, all these things that are housed within this bony thorax. But it also provides an attachment point to the muscles of respiration. Okay. And then I threw in there at the bottom the costals themselves, the ribs, do production of red bone marrow. But a lot of what we function on is you need your ribs not just for protection, but to breathe in and out. You're studying respiratory with Brazirio right now, so that's going to come in handy that we kind of look at these together, because we are going to look at the muscles, and he's going to go more. He's going to bore you to death with law. He's going to go into all these laws, and you can just chuckle in your mind. He's going to tell you about Boyle's law, and this law, and all these laws about gas exchange. I'm not. I'm going to show you the bones and the muscles that make that happen. But I was going to say your ribs are important because you have attachment points for the muscles of inspiration and expiration, accessory muscles, and along with your diaphragm. And those ribs, actually, when they contract, they're going to swing up and out. And so it's not only protecting you, it's helping to increase the size. I don't know if you have gotten into that yet. It's going to increase the size of the thoracic cavity, whether you're talking about this way or this way. He's going to get into that. But in other words, if you didn't have those bones there, it wouldn't work as well. All right, so talking about ribs, we got to decide which ones are true and which ones are false. So vertebrosternal ribs are considered true ribs. So the first 7 ribs are true ribs. Every time you're looking at ribs, especially if you're taking an exam in radiology, always number them, even on the film if you can, or at least be counting them, because you're going to be looking for levels that things are at. And so you always want to come, and I'm not going to do it on every one, but 1, 2, 3, 4, 5, 6, 7. So the first 7 are true ribs. Here's the definition of a true rib. A true rib connects anteriorly directly to the sternum. Now it uses a costal cartilage to do that, but the skeleton has them up here. So if we count 1, 2, 3, 4, 5, 6, 7. There are 7 costal cartilages connecting directly to the sternum on each side. Because of that, they call these true ribs. They have a direct anterior attachment. If you look at things like the first rib, it's going to be curved like a herringbone necklace, right? It has the big sharp curvature. And when we look at the articulation of that first rib, it's going to articulate with the manubrium just below the clavicle. So it's articulating here. So we haven't covered sternum yet, but this is the manubrium, which is part of your sternum. Right, this is the body of your sternum. So we're going to get to that. But you want to know these, especially when you're reading radiology films, so you can orientate where you're at. The second rib, if you can find that and number it, is going to articulate at what's called the sternal angle, and that's here. So the connection between the manubrium and the body of the sternum is called the sternal angle, and if you look at the second rib, it's directly attaching here. And then ribs 3 through 7 just attach down the rest of the body of the sternum. Okay, so if those are true ribs, then we got to say, well, what about our false ribs? So our false ribs are 8 through 10. Really, 8 through 12 by definition are false ribs. But there's some differences. The only reason we separate 8 through 10 are false, 11 and 12 are also false. But they separate them because 8 through 10 have a roundabout way connection to the sternum, 11 and 12 do not. So you would say that the false ribs do not have a direct articulation with the sternum. The way they're going to do that is if we look at the costal cartilages coming off of, there's 8, 9, 10, I think I got them numbered right. Here's 7. We know 7 is still a true rib. 7 has this direct attachment to the sternum. But if you look at the costal cartilages of 8, 9, and 10, they're actually joining together. They form some joints, cartilaginous joints, and they're going to tie in and use the costal cartilage of 7 to attach to the sternum. So if you come back to the skeleton, and you number them 1, 2, 3, 4, 5, 6, 7, and you look at 8, 9, and 10, 8, 9, and 10 are connecting to 7's costal cartilage. And there are, like I said, cartilaginous joints that allow them to kind of move there. So they get indirectly attached to the sternum. But since they don't attach directly, they're false. 11 and 12 are also false. The only difference being is they're kind of hard to see on here, but they do not attach to they have no anterior connection. You know, those are the ribs. Somebody taught me a new term a few classes ago I'd never heard. You know, everybody runs in different circles. And I said something about, yeah, that's the ribs people get taken out. They want that real narrow waist, high narrow waist, you know what I mean? And somebody in the front row said, do you mean, now I forgot the term, what's it, snatched? She said, you mean snatch? And I wrongly replied, and I regret half of the things I was saying, because I wrongly replied to this individual, never heard of that in my life, and that has a completely different meaning to me. I'll leave it at that. And so you get snatched if you lose these, apparently, right? You have somebody take them out. All right, go for it. To each their own. Just because we think something's silly that somebody else does doesn't mean it's silly to them. It says yes, it does. Maybe you just don't have the money to buy new clothes, so you guys, if you can't fit them, I was trying to reason through that. I don't know. Anybody looking to get snatched? Maybe later, got the money? I'll tell you this, let's leave it at this. Should never have surgery unless it's just absolutely necessary, in my opinion. Especially if anybody tells you if they say they're going to do surgery on your spine anywhere, I don't care what it's for. And if you hear these words, and tell me what the key word is here that I'm going to worry about. Somebody says, don't worry, we're going to cure your leg pain. This is going to be a routine laminectomy. Don't worry. A routine I worked in spinal cord. Guess what a lot of routine laminectomies turn into? Spinal cord damage. So what happens when you cut into somebody? Swelling? You're in that area. Am I saying don't go get it if you're miserable? No. But wait until you're miserable. Till then, you don't get up your pain meds. Alright. Looking at individual ribs, they have parts that we need to name. The head of the rib, here, it is what's going to articulate with the facet of the body of the corresponding vertebrae. Didn't we hear that yesterday? When I told you we're not going to worry about demifacets, when you look at a skeleton from behind, and on this one, pretty true, you can see that each rib, the head of the rib is going to articulate with the same vertebral body. So if we're looking at 1, 2, 3, the fourth thoracic vertebrae, the head of the fourth rib will articulate with that body. And where it does that is called a facet joint. But just in front of that, it's stabilized a little bit because the rib has a tubercle part. And I don't really care that there's an articular part and a non-articular part, but there's a tubercle here that is going to articulate with the transverse process of the same vertebrae. So you would always say that T6, or the sixth rib, articulates posteriorly with the transverse process and the body of the same numbered vertebrae. In other words, T6 vertebrae. I don't know, I've repeated that several times, so I think we're getting it, but that's where we see the connection. Just past the head, we have an area called the neck, right? As usual with other parts, bones we name. And then you have the end. This is the anterior side of your ribs. And that's close to your sternum, so that's called the sternal extremity. I know I'm going to be going back and forth for the whole rest of the time here to these skeletons, because I think it's a better example. These are costal cartilages. These are the costals, the ribs. So this is the sternal extremity of the rib, where it meets its costal cartilage. So it's closer to the sternum, so that part of the rib is called the sternal extremity. Another key area is the costal groove. So the costal groove, whatever, begins near the tubercle grade. Another thing, sometimes I start to line out things and I'm like, I don't want you to study. Here's the costal groove and what you're going to learn about it. This costal groove, if you were to reach under, and this skeleton doesn't have them, but under a real skeleton, If you reach just under the inferior portion of this rib, you'll feel that if you look up at the right, it's labeling costal groove. There's a little indented area underneath each rib back there. And that's where a nerve, artery, and vein run that go along that area. You remember back to spinal nerves. The spinal nerves, we said there is not a thoracic plexus. The thoracic spinal nerves become intercostal nerves, and they're going to run inside of that groove, which is good because it's protecting them, right? It's right behind the ribs. Actually, there is a costal groove up higher on this scope, just not low. Anyway, they run all the way along at every level. Costal angle, not so important. That's just how much angle the rib has to it. But this is the costal groove. So that's a rib, and then we got to look at the sternum. Sternum is 5 to 6 inches in adults. I don't care how many exact inches. It is composed of 3 different parts. You're going to have the manubrium, you're going to have the body, and then you have what's called the xiphoid process. Everybody knows the xiphoid process because that's what you don't want to hit while you're doing CPR, right? That fused portion down there. And there are joints that connect them. You can look at landmarks. The jugular notch. Jugular notch has 2 names that's always interchanged. Everyone's going to use a different one. It's one of those that you got to learn both. Suprasternal notch, or the notch at the top of the sternum. So everybody can actually feel your own suprasternal notch, but it's called your jugular notch also. You start looking at JVD, different things, you'll hear that again that way, but in other classes they'll say, well, that's the suprasternal notch. Okay, between the clavicles. So if you trace your clavicles back, you'll find that they're meeting up, and in between them you have the suprasternal, or what's called the jugular notch. Where the clavicles meet up with the manubrium, I thought I had a picture of it. I do, coming up in a second. It's called the sternoclavicular notch. It's because I can see like 3 different pictures. I thought different ones. Sternoclavicular notch. Sternum to clavicle. So we come back and find the clavicle, we find the jugular notch. Just here you have the sternoclavicular joints, where the sternum meets the clavicle, and just below that's where you're going to find the first rib attaching. Important landmarks. Like I said, they may not seem important here, but I guarantee if you're reading plain films and stuff, radiology, it will. Right? Y'all probably never will have to do what we used to have. Racks of x-rays in the back of the room, and during the breaks and at lunch and stuff, we would study films, right? Because we didn't do computer testing, so all we got is when they put up films and stuff. What's great about it is but here's your key, because sometimes you go backwards. You go to places, especially in the military, you get to places where all they have is that x-ray, and you don't want to look dumb. So I'm going to give you a word of advice. Is if somebody ever hands you an x-ray, you walk in there, you're the phase 2 student, and they give you an x-ray, and they say, what do you see in this x-ray? They're testing you, right? What you're going to do is you're going to look at that x-ray, we're going to take it, and you're going to hold it up to the light. Okay? What you're doing is, don't let them know this, you're looking for the radiology droppings. Because guess what they're going to do when they're looking at it? Give me a piece of paper. When they're looking at it on their screen or whatever they have it up on, right, before they come and try to pimp you on it, they're going to be there, they're like, oh yeah, you see that? And they're going to touch it. And you hold it up to the light, you will see those fingers. Right? So when they hand you an x-ray, you hold it up, you look for radiologist droppings first. You may not know what's going on in that area, but depending on how good you are at pulling things off, you can be like, something going on there. That's the key back there. Unfortunately, it worked here a few times too. Everybody's touching me like I don't know where to look. Alright, so that's good advice, but you'll probably never see a playing film anymore, I don't know. It'll always be on the computer. That's cool though, you can enlarge it, you can change contrast. Alright, sternal angle. The sternal angle is the connection between the manubrium and the body. So this is called, why it's called an angle, I don't know. It's not angled. This line here is representing the sternal angle. So sternum manubrium to sternum body. Sternal angle. You can always find the sternal angle because the second rib will attach there. It will always attach right there on most people. And in most films that you see. Alright, so this is the picture I thought I had up. So I'm going to kind of just touch on them again and say, here's your jugular notch or suprasternal notch. To each side you're going to have the sternoclavicular notch. We're only looking at the sternum, so that's where you're going to have your sternoclavicular joint where they meet up. And that means that's going to be your first rib. The sternal angle is going to be here, and that means the second rib is going to attach there. There's a lot of cartilaginous joints in this area, just a type of cartilaginous joints. So this is the body, and then you have the xiphoid process, which will fuse as you get older. I don't know if I actually focused in on it a lot. I didn't box it off, but between the body and the xiphoid process, that's just called the xiphostomal joint, and it fuses later. But, it's not fused when you're born. Right. Articulations and learning names. It's like tracks. You got to know your names. You say, well, costovertebral. So in other words, what are the articulations from costo to the vertebrae? We've already covered these. I get it. We're repeating it, but we're doing it in a manner where I talk ahead a lot of times, right? This is where you see it. If you were not to be in the class and you're going through it, you would need this slide to say, oh, those are what he was talking about earlier. Right? I just have been pointing out already. So, and then sternocostal. So a little more blown up view where you can see this is the head of the rib. This is the body of the vertebrae. This is a transverse process. And so there is a facet joint here and a facet joint here. So once again, T7 rib, the head of T7 rib articulates directly with the body of T7 and the transverse process of T7 of each one. Another key about these is if you haven't noticed yet, the posterior articulation where ribs articulate with the vertebrae are higher than they are on the anterior side. So if we look at the fourth rib, 1, 2, 3, 4, we'll see that its anterior attachment is here. If we draw this around, its posterior attachment is here. Slower. Well, that's because when you take a breath, you have a bucket handle swing of your ribs, and they'll swing up and out. Things that can throw you off when somebody's showing you chest x-ray films is, was this an inspiratory film? That kind of thing. I'm not a radiology tech. I don't know everything about radiology, but I do know that things will be out of place for what I'm looking for if somebody has a full breath versus breathing out, because the ribs are going to move up and out. And that's why you always, I don't know why I'm giving you so much radiology advice. You always, don't just look at a film and jump to something. If it's in the thoracic area, count your ribs. Because it's going to tell you what level it's at. And they're going to tell you what kind of film it is. So count the ribs. Alright, and so this is just a picture to show you what I just did. Like, so here's the anterior sternal portion of the fourth rib that you follow around. It's higher back there. I did leave this in there. So continuing with articulations, xyphosternal, xiphoid sternum, interchondral, joints between the cartilage, and then costochondral. So these are the main differences. This is a xyphosternal joint between the body and the xiphoid process. And by definition, that's a type of synchondrosis. Synchondrosis are joints that actually often fuse. When you look at interchondral joints, there are the articulations between the costal cartilages of 7 to 8, 8, 9, 9, 10. In other words, and don't focus too much on this. This is 8, 9, and 10. So each one of their costal cartilages joins with the other before they join to 7. And so what this is saying is that in each place, there's a cartilaginous joint called an interchondral joint. And it's just looser cartilage in that one area that allows it to kind of move more. Then the costochondral joint is where you take the sternal end of a rib. You have here and you have here. This is a costal cartilage. So where the rib meets up with the costal cartilage, that's called the costochondral joint. And where the chondral cartilage there meets up with the sternum, that's a sternocostal joint. So that's just another type of cartilaginous joint there. So all of this is going to allow some type of movement. It's not rigid, it's not fixed. If you had, chondral cartilage there that was just rigid, you wouldn't be able to expand your rib cage. I left those in there and mentioned them because some people can come in with what's called costochondritis. Your costochondral joints are inflamed. It causes localized chest pain. It's harmless, it's not going to hurt you. Somebody will have a viral illness, let's say they're 26 years old, healthy, military, they come in and they say they have chest pain that is really bad, they think they're having a heart attack. Okay, one of the things that you can do in your exam is to go in, because you can ask them, you've been sick lately? Yeah, I had a cold last week, or I just haven't felt well. During viral illnesses, these joints can get inflamed, and it can mimic a heart attack feel, like a bad chest pain, worse than indigestion. And the way you're going to diagnose this is part of your exam, you can come in there and push on this. If you're having a heart attack, that should not bother you. You're not going to, you're not pushing on your arteries there. You're going to push on those joints, and if that's very uncomfortable and reproduces their pain, they probably have costochondritis. So they're 26, so are they having a heart attack? Probably not. Could happen. But the key there is, I don't care if they're 26 or not, are they getting an EKG? You betcha, that's cheap, easy medicine. Why would you, don't ever jump to conclusions and not do the full exam, that's what I'm saying. I didn't want you to get down the road and go, all right, well, here they are. Oh, he's got costochondritis. I thought I'd never see that. I thought Mr. Wright was full of it. That is exactly like he described. And not do the EKG because you think I said, well, you already know what it is. No, you don't. No, you don't. So it's an idea of what it might be, right? It's time for a break. I always get off and we're off time. Let's take a break. Did he have a heart attack? That's how Tampa. Yeah, if somebody rolls up in an ambulance, because the city comes in there too sometimes. If they we roll up to the hospital and they meet them and say wants to go, I would think they're having a heart attack. They wouldn't want to go. It's just go to Tampa. Why did you even come here?
So these are like the cross sections.
That's like you took this vertebrae and you have to turn like that. You just find the crosses on that. These are the spines. It's just a little bit of it because of one. So look down here. So that's the front. It's like you cut it. You cut it right there.
So like this, not like this.
Yeah.
Shit.
Amazing how human you look when you were real close. I've been completely ignoring. I've been hiding out. Completely ignoring y'all.
Keep it quiet.
I just saw that when I looked over. I said, I don't even look over there when I'm teaching half the time. I gotta get quiet. You're not getting blind.
Yeah, it sucks though sometimes when
Oh my God. Well, just throw out like some sound or something, and I'll look over and move it towards you. Seriously. We need a signal like. So I don't mind. I'm that type of guy. I'm like, oh my goodness. You ever heard that song? Google LL Cool J. I'm that type of guy. You'll have a whole different opinion about it. He's the type of guy that's that's all he's thinking about. Now he's all serious acting. Ice Cube, and all those.
Yeah, now they're all working. Would be fairly. Here we go.
Stop talking about it, you make it down. So I'll cut it short. Alright. Tell you, sometimes I like talking to y'all more individually in class than I do being up here. That's why I run the breaks over everyone. Alright, put it on the computer. It's fine. It's more important to get to know y'all than to be on time. That's been 10 minutes. Why is everybody not back in their seats? Anybody act like that yet around here? It's coming. Just me? Jay, oh. Sorry, I was thinking instructors. Well, that's his job. That's why I get to act like a fool if you're not worried about it. It's his job to make sure. You put down a civilian there. Watch out though. So I always have to try to do on a serious statement. Don't let this semester fool you. People around here still believe they're completely in an active duty military unit. And some classes you need to know they want you in that seat, smiling, looking at them as soon as that 10-minute rolls, whether they say it or not, because they're gonna. Y'all know what I mean, right? I don't need to keep going. Some people will adjust your military attitude very quickly when that doesn't happen. Me? Nah, I just think, I get around my critique, at least one person on my critique all the time goes, he never keeps the break time, he does too long a break between the two blocks. I can't believe somebody complains about that, but whatever. This is my thought. If that meant that I was gonna come back the next hour and go, well, we took a long break, we gotta hammer this out and do these 100 slides, that's negative. You shouldn't do that. You need to get back. If you got that much info you want to put out, you need to keep the break down. Yeah, I'm defending myself now. You got a question?
I was just curious,
Nowadays, I don't even know what you're gonna ask you every time.
what was the hardest semester?
Hardest semester was a junior, because we have radiology, pharmacology in those two, and I found pharmacology was radiology was the most difficult course of that semester. It's just something I'd never been experienced. And it's hard to see. When you first start looking at radiology, you don't have as many grays that your eyes see. You really want to, like in phase 2, I went and did it. I was so worried about radiology still. They gave me an elective. And because of the way the course is, it said, hey, you need to take your one of your weak electives. You need to choose something that's going to be the first thing you do when you get there. So I chose one that wasn't really an elective, but they let me do it. I said, I want to go with radiology. I went and sat down in the radiology room with them for a week, learning how smart they were. Radiologists are a lot smarter than I thought. They're real smart. And looking at films, and the more you look at them, the more your eyes become accustomed to seeing like different shades of gray, and you start to see things easier and better. And of course, they were instructing me, so now you find it there. They're the ones who really told me about the radiology job. They taught me that because they would bust me on. I said bust me, they'd bust my all the time, make fun of me, to make me learn. People don't like that nowadays, but I did back then. That was good. How that translates to y'all is I don't know. I don't know what radiology is like now. Pharmacology is tough. All those mechanisms of actions. Why'd you ask? I always say that.
Just you always talk about like you walk these halls and like you know the stress that you do.
You don't believe me?
No.
You said prove it.
But what I find personally, like this semester, there are people in here that don't say it, that were like me. When I came to PA school and the physiology, I'm gonna be honest with you, I don't know why we're talking about this, but I'm gonna be honest. I sat right, there was only 28 of us when we started, 20, 30, we lost a couple real quick. But we only had like half of this room, so, but it was still divided, we were downstairs. And so it was set up just like this, where the podium's in the middle of the rows. The rows just weren't as long, right? And I sat right here, and Dr. Poop, Dr. Something sat here and taught physiology. Well, I'd already gone to multiple anatomy classes, not only to mention I came through here for physical therapy assistant school, so I knew anatomy. I mean, a lot of it, yeah, I'm not gonna lie, say, yeah, I remembered everything. No, but once they say it, or I'm trying, you know, anything you learn, once you go back to it, it's easier to learn it again, right? A lot of the stuff here, learn here is like that. And I sat right there and rudely, now that I think about it, had my computer up, and I played, it had just come out, just back in 2002, I was playing Tiger Woods golf.
Yes.
The whole time this guy was talking. Because he taught out of Guyton, which is a physiology book with no pictures. What in the world? And he was Ben Stein. Literally. I don't want to put him down. You shouldn't talk bad about people. But when it's true and it's hard to refute, it's not bad. Because every student that came through here, if asked, he would stand up here and he would talk, and all you hear is Bueller, Bueller, Bueller. So he talked like this the whole time, you know. And since I was very strong in anatomy, I just didn't pay attention to him at all. One reason I brought that up is there are some of y'all in here that can do that with me. And I'm fine with that. But that same person who can do that with me may not be able to do that with like biochem. They're like for me, anatomy was a walk in the park. This is gonna sound like I'm bragging. I think I missed, because we had Dr. Gant too, and he was a pushover for A&P I. Is if I missed maybe 3 questions that whole semester on anatomy, that was probably it. But I took my hits other places. That's the point I'm trying to make when you ask what was the hardest for you, because when I look at biochem, after the first chemistry test, we did chemistry, inorganic, organic, then we did some biochem. And after that first inorganic, I told y'all what I made on it, right? I thought I was going home. I'm like, this is it, it's over. Did I tell y'all that? What I made on my first exam in PA school? How can I miss not telling y'all that? I tell every class. 56. I was the average at 56. And I always tell this story of this is the first couple of weeks. This is where everything y'all hear me say comes from. Like I said, the honeymoon period, it's the first couple of weeks at IPAP. And now y'all looking back, tell me there wasn't a honeymoon period. Week or two where you're like, I'm here, ain't nobody taking me out of this place. I was built to be here. I deserve to be here. I'm happy. I'm going home smiling every day. I'm in PA school. That's that first 2 weeks, right? And then about 3 or 4 tests in, you're like, it's like somebody slapped you in the face. You're like, what the hell is going on here? I'm not happy anymore about this. And it's the honeymoon period, I call it. And I had that. So after about 2 weeks, I sat down and it was on paper. And we couldn't wait. I know y'all know what I mean now. You can't wait to get to that first test because you want to know if all of the doom and gloom that they just fed you for 2 weeks is true. Am I wrong? You want to know, is the test really going to be like that? And for some of y'all it was, some it wasn't. For me, I sat down at this, and I hate chemistry. Sat down for this test. I read the first question. I went, all right, remember, if you don't know at all, just keep going. Go to the next one. Don't stay focused on no test taking strategy. Go to the second one. On the third one, I'm not kidding, I almost raised my hand. I said, listen, this is what I was saying. If you'll tell me what language that's in, I got a better chance. Because did we even look at it? What the hell is this? Did you talk about this? I wanted to ask you. Anyway, but the average out of all 29 of us that day was 56. And I'm like, my goodness. And then like 2 or 3 days later, because we took a test every Monday, Tuesday, or Monday, Wednesday, Friday. Like the next week, the guy that helped me, so what I did is I went, I'm not going home. I got here, I'm not going home. I don't know anything about chemistry. And the guy said, well, we're gonna take organic chemistry's test next week. And I still don't know what organic chemistry is about. But I got with the guy next to me who was like a biochem major. He had like a master's degree in chemistry. A very smart person. And I got with them and other people and the instructor. The instructors really wouldn't talk to us back then, but I would try to ask him stuff. And I wound up making a 96 on organic chemistry test. And I'm not lying, I don't know anything about organic chemistry to this day, but I passed that. The guy that taught me that fell out the next week. And I was like, back then, you hear people falling out now, and you're like, hey, don't say that. Your so-and-so's having a little bit of trouble. I'm not trying to be negative. It happens, right? That's not the way it was back then. You just showed up, and they weren't there. Because I didn't know his grades. And when the guy that just taught you, and you realize he's like a genius, this master's degree, and he's gone. Where'd he go? And you went, oh, holy crap, I'm going home. So, long answer. Some people are rolling their eyes, they're done with me talking about it. It depends on the individual. What's the hardest? But I will tell you this. Whatever the seniors say, the juniors say, sophomores say, don't take that as the gospel of things. You know, Micro 3 is the hardest exam you're going to take. Maybe not. The instructors change, curriculums change, you know what I mean? You take it with a grain of salt when they tell you that. And then remember that you're smarter than the sophomores and juniors and the seniors. I already told y'all that this week, right? Not being very serious, average-wise, I think that y'all are going to kill it the rest of this. Once you get out of this semester and get reset, the next semester, y'all are going to walk all over them. Is it going to feel like that? No. Okay, enough of that. Y'all, you got me way off track, but I did it to myself. That's the true fact. I mean, look, I'm still standing here. When I came back here to teach, there was a guy that was the branch chief for Army PAs. And I happened to know the guy, and he had failed his chance 3 times. So. Y'all see kind of some of the points I'm making about this? When I tell y'all you're still going to be here, keep charging, I'm trying to be positive. The problem is I tell you all the negative things too. I don't mean to look like I'm putting anybody or the schoolhouse down at any times. The problem is people think you're talking bad about people or bad about this person or bad about a program, when a lot of times you're just speaking through facts that you went through. Does that make sense? So the way I saw it when I went through, and the way I see it from students' perspectives from being here so long teaching, whether people like the fact that you say that, I don't care. You know, I mean, that's what gets me in trouble. If it's true, all they can do is be pissed that you said it out loud. I'll leave it at that. If it's not true, then you come after you, right? So I never say anything to personally insult anybody. I'm just saying a fact. Okay. Extrinsic, I'll be thinking about that all weekend, that whole topic. Extrinsic back muscles. We have to look at the bones, and now we're getting to the muscles. And we do need to cover a little bit of this, and then we'll get out of here. We don't have to go that far into surface features of the back. Every muscle that we look at, section that we go through, I'm going to show you surface features. And they're not always that interesting. It's just showing what you can see by looking at your patient. And so I'm not really going to spend a whole lot of time on this one just yet. We're going to come back to it. Just there for representation. On the back side of your thorax, you have extrinsic and intrinsic back muscles. Extrinsic back muscles have like a superficial group and an intermediate group. The superficial group is going to be muscles that help to move the limbs. In other words, your upper extremities, your arms. The intermediate group are going to be involved in respiration. They're going to be accessory muscles of respiration. And then the true back muscles are called intrinsic back muscles, and they are muscles that specifically act upon the vertebral column. So that's how you divide them up. Superficials, moving your extremities. The intermediates, helping you to breathe at some times. The intrinsics are your true back muscles that are helping to stabilize and move your vertebrae. Your vertebrae don't move that much, so it's a funny way to think of it. But I tell you what, you get one of those muscles off and get a rotated vertebrae, like in the thoracic region, you certainly know it. So, alright, so here's your superficial back muscles. Because they are muscles of the upper extremity and not considered thorax muscles by definition, we're going to cover those in block 6. So I just gave a slide as a placeholder slide to say, well, when you talk about trapezius, levator scapulae, your rhomboids, latissimus dorsi, all of those we'll cover next test. Right. So I wrote it on there for you. Under upper limbs coverage, or you can write on the slide next test. Right. So we're not going to cover those in detail. But we are going to look at the intrinsic muscles. And they're divided up into what's called the erector spinae muscles or transversospinalis kind of group of muscles. So your erector spinae group we find runs superior and inferiorly along your back, and that's called spinalis, longissimus, and iliocostal. So these are just 3 groups of muscles that run through this area. Now these are intrinsic back muscles, which means they're close to the spine. Very close to the spine. Remember that I repeat things a lot. Any muscle that's very close to the spine is probably going to be innervated by spinal nerves. So you don't have to learn a separate nerve here, and I just left it as they're innervated by regional spinal nerves. And whatever spinal nerve they're close to is going to innervate that. And their whole job is extension, flexion, lateral bending of the spine. All of those muscles help with that. Extension, flexion, lateral bending. And that's a big bulk of the muscles you can feel. Like if you go and find, the spinous processes on somebody, generally you have a vertebral furrow where it's sunk in. You have some musculature on each side. Like if you're massaging somebody's back, you can feel those muscles. And that's part of this erector spinae group. Because the transversospinalis are down at the vertebrae level completely. But they're small muscles. So orientate this for you. This is vertebrae. This is the spinous process. This is a transverse process. And so that you can't see it because it's kind of covered up, but the body of the vertebrae is here. This is a clavicle. Sorry. It's not a clavicle, it's a rib. I don't know why it's a clavicle. Rib. So that you can see the setup. If this is the posterior side, that means that this superficial group we just talked about is going to control the upper limb. Right? And there's an intermediate level that's not really represented here well. And then you have the erector spinae group here in yellow. And then deep to that, going between different parts of the vertebrae, you have other muscles. And going between other vertebrae too. Don't spend a whole lot of time on them, just realize that they are the transversospinalis group, and you have this rotator, multifidus, semispinalis. Probably never asked you that. You're welcome to write that. I want to show you the separation of muscles. I'm not going to start throwing out multifidus muscle and what it does, because we didn't really spend a lot of time on it. So just so much you can recognize that you have a superficial and intermediate and a deep group, we're going to be good. Okay. So we have, and I don't know why we got to say they're imaginary. The book always says, well, here's a picture, and these are imaginary lines on the body. Because unless somebody's got some tattoos that are kind of weird, we know that these lines don't exist. Just trying to be a little funny. Imaginary lines. Most of y'all, especially if you're medical before you got here, have heard of one of the main lines, the mid-clavicular line. You start talking about things like needle decompressions in the intercostal space, mid-clavicular line. So these are lines that we use for things like emergency medicine locations, but also we use these a lot for like dermatology descriptions when you're writing referrals. So here's your anatomical lines. we're gonna break them down and say, there is a clavicle here and a clavicle here, and so you have the mid-clavicular line. Sorry, it's hard to draw straight this month. Mid-clavicular line. And then down the middle, straight down, what we would call the sagittal plane. They draw a line down the body though, and they call that the mid-sternal or anterior median line. But it's going right down the middle. If you look laterally on the body, you could say, well, we have the anterior axillary line. So this is the anterior axillary line, and the border of pectoralis major is what defines that line, where we start to look at it as being a line on an actual person. It is important for you to pick up for your memory for testing. If it says the pectoralis major forms the anterior axillary line, I need you to know that. You're going to need to know that in physical exam. So, then you have the mid-axillary line that goes right through the axillary region. And then behind that, you're going to have the posterior axillary line. And its borders are formed by latissimus dorsi and teres major. Whether you know what those muscles are or not, right now it's just, that's what forms them. If you go completely posteriorly, we have three lines back there too. We have the scapular lines that go down through the scapula. If you, once we study the scapula here under the upper extremity, we would actually see that your scapula is back here and it kind of goes down. And it makes, it's called the inferior angle. This is the inferior angle of the scapula. And so the scapular, sorry, the scapular lines go straight through there. Now that's another thing that I wasn't there when they decided to name these. Because if I look at the front, for me, if I was going to name these the mid-clavicular lines, and I know that these lines go down through almost the middle of the scapula, I would have called them the mid-scapular lines, but they didn't do that. That's another one of those things y'all don't care. What are they called now? They're scapular lines. And then you have a line straight down the vertebral spinous process, is essentially called the mid-vertebral or mid-spinal line. So all of these are used for descriptions of things and where it's located, where you're going to do chest tubes, needle decompressions, where dermatology referrals, that kind of stuff. So it is important. You will see that again in physical exams. So you need to know this. All right, we're getting close. Muscles of the thoracic wall. When you say muscles, this is where we start to see a little grouping of names. So there are muscles that control your upper extremity that are considered intrinsic. Intrinsic muscles, for the most part, would be out here in the extremity. But some muscles originate off of the thorax and go out to your extremity. Okay? So they give them a special name. They're called thoracoappendicular muscles, thorax to appendices. So when you look at the anterior thoracic muscles, or what's sometimes you'll hear axial muscles, they are thoracoappendicular muscles and are generally considered part of the upper limb. Even though they originated on the thorax, because all their action goes to the upper extremity, we study them under the upper extremity because they're considered part of it. But there are also muscles that help you with breathing. And we have a diaphragm at the bottom part of your thoracic cavity, and then we have the scalenes we discussed. And most of these, when you look at respiration, most of these are accessory muscles of respiration. And I know you're doing respiratory, and I'm going to say it once so you keep hearing it, is there is a difference, and I don't know what he's discussed yet, between normal quiet breathing, I've told you all this before actually, right? Normal quiet breathing and exertional breathing. So when you're breathing, like sitting here right now, normally you're not out walking around running, your diaphragm is the chief muscle of inspiration and expiration, because when you breathe in, your diaphragm contracts down and increases the volume, size, and air comes in. and then it relaxes, and the lungs recoil and goes back out. So normal quiet breathing, expiration is completely passive. Inspiration uses your diaphragm and your external intercostals. Every other muscle that we mention that you say, well, that's a muscle of respiration. Well, every other muscle is an accessory muscle of respiration. That's why we see these asterisks here, like thoracolapticular muscles, some intercostals, scalenes. There's an asterisk because we discuss them in other places because they're accessory muscles of respiration. Okay. So having said all of that, that means that we get kind of the same, we add a few, but we have the posterior muscles, like we said, latissimus dorsi is going to be under block 6, upper extremity. So are the anterior type muscles. So pec major, minor, subclavius, serratus anterior, and then posterior latissimus dorsi. Once again, all of this will be on test 6, so we're not going to look at those just yet. But we mention them because they come off of the thorax. And then probably the last part that we'll get through today, we're going to cover our intercostal muscles. Okay. So intercostal muscles are in between the intercostal spaces, they're in between the ribs. 3 different layers. You have external intercostals, internal intercostals, and then that wasn't enough, so now we have an innermost layer. Love this. I love this part. Now we got to make it real good. The innermost layer, luckily I'm not going to focus in on it that greatly. The innermost layer has a transverso thoracis, subcostals, and then they throw this one in for the big loop. Innermost intercostal muscle. Under the innermost layer. Golly. That's somebody, that's a badge keeper right there. What's that? Another ER boy. All of the intercostals nerve innervations are easy because guess what innervates them? Remember those spinal nerves for the thoracic spinal nerves? They don't go into a plexus once again. They run along the ribs of the costals, and they're going to innervate all the muscles. So you don't have any separate innervation for them. They're all innervated by the intercostal nerves, each segment of them. So the outermost layer, the external intercostals. If you were to remove pectoralis major, you can start to see these muscles. Now this is going to be confusing for a second, but I want you to remember this. You do not have to learn origin and insertions. Remember I told you I'm going to tell you some, a lot. So you don't have to memorize them verbatim. So let's see what they're saying here. Travels obliquely, lateral to medial, downward from the inferior border of the rib above to the superior border of the rib below. Yeah. That doesn't sound confusing until we say the next slide. So external intercostal's job is to elevate the ribs. I'm going to drop these pictures. External intercostals go this way, across. They're angled kind of. They're like this. Oh, man. You didn't get a signal yet. Like this. Lateral, like you're putting your hands in your pockets. Same thing is going to be with the obliques and abdominal. Like you're putting your hands down there. That's the way the external intercostals run. And they originate on the inferior border of the rib above, and they insert on the superior border of the rib below. The reason that's important when you're actually studying this is, remember, insertions get pulled towards the origin. And so if I contract this muscle, I'm bringing it this way. Right? It's hard to bend that paper now that I folded it up. So it's coming this way. So we're going to pull the ribs up. Right? Contract. And that will expand your rib cage. Okay? When we look at the internal intercostals, they do the opposite. And it used to be one of my favorite questions because it's just, when people are learning them, I don't ask you this anymore because people get tripped up and they don't figure it out, it seems like, for some reason. Originate on the superior border of the rib below and insert on the inferior border of the rib above. So they're doing just the opposite. You know, and I'm joking, it wasn't one of my favorite questions, it was something I used to ask. So now we're going to go be orientated at a 90-degree angle, and we're going to go and say, well, when you look at internal intercostals, they originate from the superior border of the rib below and insert on the inferior border of the rib below, above. So when they pull, they're going to pull this way. They're going to pull it down. So they're going to depress the whole rib cage. So they're considered muscles of expiration. Or forced expiration. When you look at all these, I'm going to keep going because if you can't figure out in your head where they originate and inserted, remember that's not important. Unless you just want to know, come talk to me. I showed you, but you don't have to figure it out. I'll show you again on here all these. If you draw a line through this, they're trying to represent, you see this picture a lot in respiratory. Muscles of inhalation or inspiration, same thing. Exhalation, expiration. And over here we have our external intercostals, and they're going to pull this way, bring the ribs up and out, and your internal intercostals are going to bring it down. And this chart lists a lot, we're not going to get into the abdominal yet, but it throws in there, you have your scalenes and your sternocleidomastoid. All of those muscles can help if needed to increase the size of the thoracic cavity. That's the respiratory physiology side that I don't cover. I almost call it Riggins. I do it on Friday Night Lights, but Ruggiero does. Okay, the last few of these transverse thoracic muscles originate on the sternum and insert on the cartilages, rib 2 through 6. What we're talking about, these are the ones that we don't spend as much time on. This is a transverse thoracic muscle. And they help to depress the ribs. Then you have subcostals. Subcostals are similar to internal and external intercostals, except they span 2 intercostal spaces. So a subcostal would originate here and here, but then it spans, this is 1 space, this is 2 space, because internal and external intercostals only span 1 space each, right, at every level. So a subcostal goes across both. That's the only thing to think about. They're probably muscles of inspiration. Some of these are not exactly sure, and that doesn't make for good questions. And that's why I said I don't have to focus much on them. Because then you get to that crazy now, innermost intercostal. That's a very thin layer that goes from one, it's kind of orientated straight up and down vertically. And I don't like to ask questions about anything that says probably. Remember back to facts. Probably are muscles of expiration, but I don't know how they'll ever really determine that. They exist there. Okay. Nerves of the thoracic wall. When you look at the intercostal nerves, they're extensions that came off the spinal nerves. So you have 12 pairs of thoracic spinal nerves, and the distribution is here are our spinal nerves coming off. And we're going to see how they go around. I'm going to go to this one. So remember when we came off of the spinal cord itself, we had anterior and posterior rami. The posterior rami, I always said, is going to go to the back muscles and the overlying skin. That always happens. But the anterior rami that come off are going to go around and form the intercostal nerves. They're going to run intercostal groove around and innervate those muscles of inspiration, expiration. Just for fun, what do you think this yellow is representing here? Ah, which ganglion? Sympathetic trunk. Sympathetic trunk. We're not going backwards. I'm not going to start asking you questions about the sympathetic trunk. I just threw it out there for, make your brain hurt a little bit. Alright, dermatomes. If you look at dermatomes of the thorax, this is where, remember last test, we were looking at dermatomes, and I said we don't need to know the dermatome chart just yet. Well, we've changed that now. I flipped it on you. Now you do need to know it. for the thorax. Meaning, you don't need to know the whole dermatome chart, you need to know the thorax region. We already know C5, or cranial nerve 5, sorry, not C5. Cranial nerve 5 is a V on the face. We said yesterday that C2 was your drill sergeant's bump. But what else is that? This is the difference between a good example of dermatomes, like peripheral nerve fields. Because I've told you two different things for the area surrounding the drill sergeant's bump. I said it was C2, dermatome, but what is its peripheral nerve field's nerve? Greater occipital. Right? So I'm trying to clear up a point of confusion when you start studying this again. Those both exist in the same world, just one's a dermatome, one's a peripheral nerve field. Right? Or an individual nerve. But when you get below that, we said that C3 is a gentleman's collar. And then you don't have to memorize every single number on a dermatome chart, because once you get out there, if you're using dermatomes every day, a lot of times, or you're doing a quick dermatome check on somebody, you're going to use landmarks. And it's going to be an estimate, because if you Google dermatome chart right now, you get dermatome charts that look different. There's all slight variations, but you got to stick with something. And so the book goes with this one and this is what I learned, is if you look at T4, that's the nipple line. If you look at T10, that's your umbilicus, your belly button. If you look for the suprasternal notch, that's the beginning of C4, or the separation between C3 and C4. Now, because everybody visually looks at things differently, I gotta say this, ever since somebody asked me this, I can't get away without saying it. The dermatome on this chart, y'all are gonna be like, yeah, that's easy. Well, they didn't think so. The dermatome is, for T1, is from there to there. All of us fill in, all of this area is the T1 dermatome. Okay, I had somebody, I was asking about dermatomes, and missed the question, and they said, well, I thought the line was the dermatome. Now, I didn't buy that for a second, but I did know that they were serious. So I say it to every class now. On the chart, it's everything in between. Nipple line's T4, umbilicus is T10. Other than that, you can count, right? Count up and down. It's a book picture. Okay. Here's a more defined explanation of what I'm saying. I'm giving you this for physical exam, because you're going to hear this in physical exam. But the ones you're going to remember is T4 and T10. But if you really wanted to go into depth, you could say, well, the jugular, they call it jugular C5, meaning that's where, I said it wrong earlier, where C4 and C5 meet, not where C3 and C4 meet. That's your C5 dermatome start. And then T7, which is xiphoid process, T1 inter. Don't remember all those. Just remember T4, T10, and you'll be fine. Gentleman's collar, those generalized things. When you look at T1, there's a difference that it's the upper dermatome of the thorax that we see at the back that does not supply the upper extremity. Now don't get too far into this now, because we're going to look at the upper extremity dermatomes. But on the anterior side, dermatomes generally, the front here has T1 dermatome that goes into the upper extremity. It's just to help you count these off. When you look at the back, it does not go directly into the upper extremity. So if you can find where the axillary line starts, that's T1, and you can just count up or down from there. You know, some people will say, well, T5 is the inferior angle of the scapula. Okay, well, I can't see the inferior angles on there very well. Other than that, I know where they're at. Alright, so that's what we're going to do and call it a day. I feel like there are multiple things in that block that I kind of was glazing over, like, hey, yeah, don't. If you didn't get what I was saying when we went through it, come back and ask. You know, like getting into what all these external intercostals, internal intercostals, those are important muscles. When you're getting down to the innermost intercostals, saying it probably does this, I was trying to say, like, I ain't asking you that. So if there were some of those today that you didn't get, whether they're important or not, ask me, okay? But I'm trying to give you some keys to not study a few things. You don't know what those were, ask. Alright? Y'all have a wonderful, wonderful